Alright, so now moving on. This is a bonus session I'm doing on a Sunday afternoon just because I happen to be home. We're moving on into the disorders of the small bowel, which are pretty high yield when it comes to CK. CK tends to really like questions on disorders of the small bowel. The first thing they talk about here is diarrhea. The most common mechanisms are malabsorption, osmotic, secretory, inflammatory, infectious, and increased motility. So yeah, we'll come back to this table. But then stool electrolytes are one of the key things to check for. So primarily sodium and potassium, and even in step 1 and NBME questions, we've seen many times questions about people who are having chronic diarrhea and what happens to their electrolyte imbalances, right? So primarily sodium and potassium. Normal stool osmotic gap is 50 to 100. Right? Stool osmotic gap is basically 290 minus 2 times the amount of stool sodium plus stool potassium, right? So the way I like to think about it is that if you're having diarrhea and you're pooping too much, you're losing your sodium potassium ATPase activity. It's not what it truly is, but I like to think of sodium potassium ATPase as something that gives you energy, right? It's an ATPase. It's a very important ATPase that's there when you're healthy and well. If you're having excessive diarrhea, you can imagine the person's going to become quite weak, so they lose sodium and potassium. That's what I imagine in this scenario, okay? So you lose all of that, and to calculate the osmotic gap, you just do 290 minus double that amount, right? The amount that's in the stool. And once you see that this is actually different from the normal osmotic gap, that's when you kind of know something's wrong. So history-wise, with acute diarrhea, you're going to have an acute onset with a duration of less than 2 weeks, usually infectious and self-limited. There are multiple pathogens that are responsible, which kind of brings you back to, right, causes of infectious diarrhea, basically step 1, microbiology. So we'll come back to that. We'll come back to these guys and talk about them. Common causes of pediatric diarrhea are rotavirus, Norwalk virus, and enterovirus infection. These are the ones you'll be thinking of for pediatric cases. With chronic diarrhea, you have insidious onset with a duration of more than 4 weeks. So then you have to consider something else. This probably isn't just due to some kind of infectious issue. So it could be secretory, maybe due to a carcinoid tumor or a VIPoma. Remember that carcinoid tumors could originate in the small intestine or originate in the lung. When they originate in the small intestine, they go to the liver, and then they come into the right side blood circulation and come back to the right heart, thereby messing up valves in the right side, right? So you start noticing right heart valvular issues, right? And then if the carcinoid originates in the lung, then remember that in the lung you have your MAO-A enzyme, which actually degrades the products of carcinoid, mainly the serotonin. But if your carcinoid actually originates in the lung, then it's too much for the enzyme, so that blood actually comes from the lung into the left heart and manages to mess up your left heart valves, possibly causing mitral regurgitation. So usually carcinoid will cause tricuspid regurgitation because it's usually intestinal, right? And then from the small bowel it goes through all this metabolism and never makes it back to the left heart. But if it actually originates in the lungs, that's different, right? So that's one thing that can definitely cause diarrhea. In that case scenario, you would see diarrhea, wheezing, and flushing. VIPoma is the watery diarrhea with achlorhydria, right? So those are the two things you want to make sure you go back to first aid step 1 and kind of check out. So they were kind of discussed in endocrine. So let's see, I think it was right here somewhere in endocrine pathology, right? So here we have our carcinoid syndrome. And so carcinoid syndrome with the MAO-A enzyme, mostly affecting tricuspid valve and pulmonic valve, right? Because it'll be in the right heart. You have your small blue cells and the entire neuroendocrine aspect of things, right? So the rosettes over here. This is basic stuff that you should definitely revise, and the fact that there's also a bronchial version of it, right? So there's a bronchial carcinoid also. You want to make sure you know that one as well. And this is all just excess serotonin activity, right? And then the VIPoma, that's this up here, right? Watery diarrhea, hypokalemia, and achlorhydria, right? So these are just main facts. You just want to make sure you have. VIPomas are very rare, but when they do occur, you want to consider the association it has with MEN1 and rule out any other concurrent MEN1 issues the patient might have, all right? So those are your secretory versions. If it's malabsorptive, maldigestive, or osmotic, then you want to consider bacterial overgrowth, pancreatic insufficiency, mucosal damage, maybe it's lactose intolerance, and they'll tell you it's related to every time they have milk. Could be celiac disease, then they might have other concurrent issues. You have to go back and revise the fact that celiac disease could also have other presentations, right? The patient will have the herpetitis or herpetiformis thing, the herpetiformis lesions that occur on the arm, right? So that's again step 1 GIT. So if we go to pathology here and we come down to after the stomach and peptic ulcer stuff that we've been looking at, you have your malabsorption syndromes, right? So you see this stuff can pop up in celiac disease patients because they have the which one is it? Let's see, the anti-transglutaminase, and then the anti-nemesyl, anti-deaminated gliadin. Gliadin is the main thing that celiac is responsive to, right? Gliadin, gluten protein. But they have dermatitis herpetiformis because of the anti-epidermal transglutaminase autoantibodies, as I'm explaining right here. And so this could be something you'll see in them, and then you consider celiac disease for that patient, right? Laxative abuse, for sure, another thing you could look for, and post-surgical short bowel syndrome. When you do your CKU world questions, you're going to see pretty much questions for almost all of these. The inflammatory infectious ones are different. These can often have bleeding, right? So there's going to be blood in their diarrhea, especially with the inflammatory bowel diseases. Then there's giardiasis and amoebic dysentery, right? So dysentery is bloody diarrhea. The last one is increased motility, which is usually due to irritable bowel syndrome, IBS, right? So IBS is interesting. This one usually has a psychiatric connection to it, and it can also alternate between diarrhea and constipation. So for the diagnosis, with acute diarrhea, you don't really need to do anything. It should resolve, and you just give supportive treatment. Usually you just tell them to drink a lot of water, take electrolytes, have some Gatorade, they'll be fine. With chronic diarrhea, you do a history or physical exam to narrow down the differential diagnosis. Additional studies include the following. You can look for leukocytes, do a culture if necessary, C. difficile toxin, you can check for that, and ova and parasite exam, right? So the ONP, check for that. Maybe some kind of parasitic infestation in their intestines is causing the chronic diarrhea. But overall, the cause of chronic diarrhea usually isn't the hardest thing to figure out, so you should be able to find out what it is. Right, so again, C treatment, just oral rehydration is key. Right? Antibiotics are not indicated except for C. difficile because they do not shorten the course of the illness. Right, so you never want to take antibiotics if it doesn't help. And chronic diarrhea, you just find out what's causing it and then you treat that specific issue. Right? Now coming back to the causes of infectious diarrhea, if you go back to your step 1 book and under microbiology you go to where it's systems, right? Then here you can see all the different causes being broken down, and the first thing they talk about is bugs causing diarrhea. So they have a nice little summary that you can definitely utilize. They break it down between bloody diarrhea versus watery diarrhea, and when you check these things, you should definitely see what you'd be looking for, right? So stool findings, you could look for fecal polymorphonuclear leukocytes with or without red blood cells. Right? Salmonella will have fecal mononuclear leukocytes only because of many of the traits of Salmonella and how it is, right? It's a non-typhoidal, lactose negative, flagellar motility, has animal reservoir, especially poultry and eggs. Watery diarrhea here for C. perfringens, I wrote that you're not going to see any fecal leukocytes, right? For C. perfringens because Clostridia, they're all very unique and different. Right? So this is just a basic summary, but it's very good to get you to kind of revise it all one more time, right? You get a good idea of what they're like, and you could revisit each one within the microbiology chapter to see any more information you might want on them. Here they go into a pretty simple breakdown to get you to understand the basics of it all. So Campylobacter is the most, this one is very common, and the most common etiology of bacterial diarrhea caused by ingestion of contaminated food or water, and it usually affects young kids and young adults. It'll last almost 2 weeks, right? 7 to 10 days, and frequently does present with bloody diarrhea. Rule out appendicitis and inflammatory bowel disease. Supportive treatment is first, then you could use fluoroquinolones or azithromycin. So let's go look at Campylobacter real quick. So that's in your bacterias. Let's see. No, not there. Campylobacter. Yeah, here we go. So Campylobacter jejuni, right? #1 cause of acute gastroenteritis in kids and adults in the industrialized countries. Gram-negative, or S-shaped with the polar flagella. It's also oxidase positive, which, remember, this middle image is the one from Sketchy Micro for C. jejuni. And the oxidase positivity was always reflected by a blue ring. Now, the image I have here, he's wearing the ring, but it's not complete. It's supposed to be colored blue. They couldn't do it. This one here, you can see in Vibrio cholerae as well, also oxidase positive. The blue ring was the symbol for oxidase positivity, and my image is just not complete in that aspect. That's why you need to go watch the Sketchy Micro videos to really see it all in action. So this is a camp. The stools are red because it causes you to have red stool. Right? It usually affects young kids, so you have these cubs. Major cause of bloody diarrhea, especially in kids, fecal oral transmission through person-to-person contact or via ingestion. This is why you have all these kids playing with each other and this one eating it. Right? On top of that, if you look at all of these hot dogs, they look like connected nerves because it actually can lead to Guillain-Barré syndrome, which will have an ascending paralysis due to demyelination of peripheral nerves. Right? So that's why they have that there. And you see this one here, it's wrapping around his legs. Right, because it's an ascending paralysis. Starts from the legs, goes up. Right, so that's something you want to really keep in mind. One of the other things is the reactive arthritis it can have. So this guy is watching them all play and he's laughing at it, and he's reacting to them by laughing and smacking his knee. So that's your reactive arthritis right there. Right, so it's really rare for someone to have diarrhea and have arthritis at the same time, acutely. Right, so if you see that, then you think of C. jejuni. Next guy, Clostridium difficile. This is associated with recent treatment with antibiotics like penicillins, quinolones, and clindamycin. Antibiotics can often kill the normal gut bacteria. Since this is related to antibiotics, you imagine who would be taking antibiotics? Well, people don't really get antibiotics prescribed that easily anymore, so it's usually someone who's already in the hospital. So it affects hospitalized adult patients. Watch for toxic megacolon, where you would see it on the x-ray as their colon gets huge. Presents with fever, abdominal pain, and possible systemic toxicity. So what do you have to do? Well, most commonly causes colitis, but can involve the small bowel. And it's first thing you need to do is identify the C. difficile toxin in the stool. You stop the inciting antibiotic, and you treat with PO metronidazole if it's mild disease. You can treat it with PO vancomycin if it's moderate to severe disease, or IV metronidazole plus or minus rectal vancomycin if there's ileus. Now there's a special medication, fidaxomicin, when there are multiple relapses on previous antibiotics. Right? If it keeps happening, you start them on fidaxomicin. So that's the entire breakdown here and in this table. All right, very important stuff. Echinococcus granulosus. This guy is contracted from close contact with dogs, which are the definitive host for tapeworm. Causes simple liver cysts, right? Eggshell calcification on CT scan. Usually found incidentally, but may cause mild right upper quadrant pain caused by compression of other structures. Cyst aspiration may cause cyst rupture and anaphylactic shock. Surgical resection and albendazole are the main treatments. So this you're going to see, let me see if I can find it. Yeah, it should pop up right here. No, not the candidates. Yeah, Echinococcus granulosus, right? So we're looking at images C through E. So this is the actual bug, right? D is showing you the hydatid cyst, which is going to have the eggshell calcification in the liver. And then, in E here you can see the eggshell calcifications, all the different eggshell calcifications inside. There's a bunch of little things in here. The gray circles, that's what you're looking at. So eggshell calcifications in the liver, you can see it on CT. And albendazole is really the only thing you can do. Right? Surgical resection is for the cysts, all the cysts. But you have to be very careful. If you rupture the cyst, it'll cause anaphylaxis. So it's a very sensitive thing to treat. Very rarely an actual question on step. E. histolytica, Entamoeba histolytica. This one's also pretty rare, caused by ingestion of contaminated water or food. Look for a history of travel into developing countries. The incubation period can last up to 3 months, so they might have traveled almost 3 months ago. Presents with severe abdominal pain and fever, and when you do endoscopy, you note this really interesting flask-shaped ulcer. So what does that look like? So, flask-shaped ulcer, Let me see if I can find Entamoeba histolytica. Entamoeba histolytica. So right here, the first guy. Right? First page, I mean. This is it. So you see this ulcer, it extended a little extra towards here. Right? But what they're really saying is that it's got a flash shape to it. So it's like, this is, I wish the white part was separate, but basically, let me grab the pencil again. Basically, this is your flask. Right here. Right? So that's your flask-shaped ulcer. Very strange kind of ulcer to have. Amoebiasis is basically going to present with a dysentery, a liver abscess that has anchovy paste exudates, and right upper quadrant pain once again, just like the previous one, right? Just like your Echinococcus granulosus, right upper quadrant pain. So they both have that. And then, of course, for treatment, metronidazole, but you could also use paramycin or iodoquinol for asymptomatic cyst passers. Right, so this one is pretty special though. They love asking you about this. It's called Entamoeba, right? And it's actually the one that eats erythrocytes. Okay, so you can see that in these images here. Right, you're gonna find in serology, you're gonna find trophozoites that have engulfed red blood cells. Right, so that's the interesting thing that you note there. Their picture was very complex. There was a lot happening in it, but you know, if you do Sketchy Micro, you'll learn about that. Then they go on to E. coli. We're very common, right? And this has happened even in America. Caused by ingestion of contaminated food, raw meat mainly, affects kids and the elderly. Generally lasts about 5 to 10 days again. Presents with severe abdominal pain, low-grade fever, and vomiting. It is important to rule out GI bleeding and ischemic colitis. Kids can actually end up getting hemolytic uremic syndrome, a potentially complicated issue, and it's related to renal issues. Right? And then avoid antibiotics or antidiarrheal therapy, which actually increase the risk of getting hemolytic uremic syndrome, which is really bad. Right? So you have to make sure when you see this, you just manage it the best you can in terms of rehydration and stuff, and they should be okay. Again, most acute diarrhea cases are self-resolving within the month. Right? Salmonella caused by ingestion of contaminated poultry or eggs affects younger kids and the elderly. Generally lasts about a week, 2 to 5 days. Presents with a prodromal headache, fibromyalgia, and abdominal pain. Sepsis is a concern, as 5 to 10% of patients become bacteremic. So that's something you have to check for. And then if the patient is a sickle cell patient, they're even more susceptible to invasive disease, which can lead to osteomyelitis. Right, so this one is very critical, because if you ever needed to consider osteomyelitis in a sickle cell patient, you would think of salmonella as the answer. That was the step one thing. So of course, treatment always, with all diarrhea, the first thing is to do fluids. And then with salmonella, you have to treat the bacteremia or at-risk patients with oral quinolone or TMP-SMX. But remember, TMP-SMX you can't give to anyone with a sulfa allergy. Shigella, extremely contagious. You don't really need too many colonies of this. Only up to 10 pieces of Shigella alone can just cause really bad disease. Transmitted between people by the fecal-oral route, affects young kids and institutionalized patients. Right? May lead to severe dehydration, can also cause febrile seizures in the very young. And again, trimethoprim sulfamethoxazole is basically all you're going to need there. Taenia solium is mainly just related to pork, right? Acquired by ingestion of undercooked pork. Presents with signs of elevated intracranial pressure, so all the headaches, vomiting, seizures, visual changes, right? You're going to have elevated intracranial pressure, which can lead to all these symptoms. Diagnosed via CT or MRI, showing several cysts with edema. Treat with albendazole and with symptomatic management of CNS symptoms. And then the last one, trichinella, acquired by ingestion of undercooked meat in developing countries like Mexico and Thailand. Classic triad of myositis, peribral edema, and eosinophilia. If you ever see someone with these three symptoms, you immediately think of trichinella and you're done. Multi-organ involvement is also possible, so there would be some other things there. Always a good idea to go back and revise some of those guys to get it down pretty well. Right? Here they're talking about dermatitis herpetiformis, which is the thing you see in celiac disease. Right? So it's always, this is something you want to get very accustomed to. This is also extremely important for students who are coming from the Eastern countries, because when you start practicing medicine, you're going to have to be able to describe things to your attending over the phone, for example, right, without any pictures and videos. So you're going to have to know the wording to describe something that looks like this, right? Grouped papulovesicular pruritic skin lesions that are shown. This would be itchy. Lesions tend to be symmetrically located on the extensor surfaces of the elbows, knees, and buttocks, and posterior scalp, and are associated with celiac disease. Right, so that's under your malabsorption and maldigestion issues, right? Bile salt deficiency is something that is related to ileal disease and Crohn's disease or small bowel resections. Right, so this is something really big in Crohn's disease. They loved that topic. If we go back to my GIT book and step 1 and we jump straight over to Crohn, you see that with Crohn and ulcerative colitis, there were extra intestinal manifestations, right? Like erythema nodosum, pyoderma gangrenosum, all these kinds of things. Mainly with Crohn's disease, because Crohn's disease is a lot more than colitis. Ulcerative colitis is just a colitis. It's just inflammation of the colon. Crohn's disease is a very bad disease, much worse than ulcerative colitis, and the extraintestinal manifestations there are just extremely bad. Now, one of the things you would see is impaired bile acid absorption in the terminal ileum, leading to a loss of bile acids in the feces with subsequent fat malabsorption. Lipids then bind calcium ions, but oxalate is supposed to bind to calcium ions. So now you have a bunch of free oxalate that's absorbed, forming urinary calculi. So, in Crohn's disease, because they don't have bile acid, they're going to end up getting urinary calculi. Right, and that sucks. It's going to be calcium oxalate. So why did it happen? Because lipids that were supposed to be absorbed aren't going to be absorbed. So all those lipids are going to bind calcium ions. Right? Lipids bind calcium ions. Oxalate was supposed to be the one binding the calcium ions, but it can't. So all that oxalate comes to the kidney, and then they get urinary calcium oxalate stones. And so kidney stones that are calcium oxalate, they can also get gallstones because of bile not really moving much. Right? So very, very high-yield topic. They love that topic. They love asking about it and the mechanism of it when it comes to Crohn's disease. And Crohn and ulcerative colitis have a lot happening. So we'll come back to that pretty soon when we get to that here too. That's going to be a GI bleed and IBD topic right there. Lactose and carcinoid, we already talked about. Then you have your irritable bowel syndrome. This is usually just going to be someone who has psychiatric issues as well. So this is an idiopathic functional disorder that commonly affects women in their 20s to 30s. Often patients have comorbid psychiatric disorders like depression, anxiety, and fibromyalgia. Right? Patients present with abdominal pain that is relieved by bowel movements, diarrhea, and/or constipation, abdominal distension, and mucus stools. Symptoms often worsen with stress. No alarm symptoms like bleeding or awakening from sleep, vomiting, any significant weight loss, nothing. No red flag symptoms. That's what they mean by no alarm symptoms. Right? Nothing on physical exam. So what do? Well, per Rome 3 diagnostic criteria, at least 3 days in 3 months of episodic abdominal discomfort, that is 2 or more criteria, either relieved by defecation, associated with a change in stool frequency or consistency, or associated with a change in stool appearance. When you see that, that's how you diagnose it as IBS. Exclude organic disorders such as IBD, increased prevalence of celiac disease in IBS, so celiac should be ruled out when IBS is suspected. Right? Treatment, psychosocial, diet, and pharmacologic. The pharmacologic is very rarely actually done, but you could use TCAs and SSRIs. However, patients are very reluctant in actually taking these because these are often referred to as antidepressants. Right? So they're not fond of the idea. So that being said, after all those topics, let's take a look at this question right here. 58-year-old man comes to the physician, got the pencil, with a 1-year history of diarrhea. Okay, so he's got chronic diarrhea, right? There's a 1-year history of diarrhea. Perfect. Stools are watery and accompanied by abdominal cramps. He has no fever, blood from the rectum, or foul-smelling stools. He has also experienced frequent episodes of dizziness, right, flushing and wheezing, and a feeling of warmth. The patient has taken herbal medicines which failed to relieve his symptoms. He is depressed about his illness and feels hopeless about the diagnosis and treatment. He appears ill. Cardiac auscultation shows a 2 out of 6 systolic murmur over the left lower sternal border that increases with inspiration. So now you see how they would love to ask you questions about carcinoid, because this cardiac exam is now allowing them to have a GIT question that relates to cardiovascular. We'll come back to that. Abdominal exam shows hepatomegaly, 3 centimeter below the right costal margin. Lab, so he has hepatomegaly, so we underline that too. All right, that's a terrible underlining. Underline, okay. Hemoglobin is fine, MCV 90, platelets are fine, leukocytes 6100, alkaline phosphatase 400, that's pretty high. AST and ALT are also high. This patient is at greatest risk of developing a deficiency of what vitamin? So now you see how the CK question is practically sounding like a step 1 biochem nutrition question, right? And this is such a nice topic because it relates to GIT carcinoid, respiratory symptoms, cardiovascular symptoms, and now nutrition. So you're going to run out of niacin, right? Because his clinical features of flushing, wheezing, and diarrhea with the valvular heart disease of tricuspid regurgitation are the perfect clinical picture of carcinoid syndrome. Carcinoids are slow-growing tumors found mostly in the distal small intestine, proximal colon, and lung. Right? But the lung one is a separate case scenario. The lung one affects the left heart. These tumors can secrete several products, histamine, serotonin, VIP, that are metabolized in the liver. GI carcinoids often metastasize to the liver. In such cases, the liver is unable to metabolize these hormones before they are released into systemic circulation, leading to carcinoid syndrome. Other clinical features include cutaneous telangiectasias and tricuspid regurgitation. Right, serotonin is actually made from tryptophan, which is also made using niacin. So niacin makes tryptophan, and tryptophan makes serotonin. So if you're doing this and you're making a lot of serotonin, you're going to run out of niacin. That's it. For some reason, 30% of people chose vitamin A deficiency, and I'm not sure why. I can't imagine what the other answer choices might have been, but if they thought that this question was related to having a deficiency of fat-soluble vitamins, then it kind of makes sense. Then I can imagine, okay, sure, you know, fat-soluble vitamin deficiency, but I don't see how you would come down to a fat-soluble vitamin deficiency thing. This cardiac exam of a 2 out of 6 systolic murmur, so it's occurring when the ventricles are contracting, and it's in the left lower sternal border, so that's APT, right? So that's in the T area, the left lower sternal border, which is tricuspid, and it increases with inspiration because during inspiration you add more blood to the right heart. Right? So this during systole, you remember your D arms mnemonic. D arms is diastolic, is aortic regurgitation. Right? D, diastolic murmurs are aortic regurgitation, and mitral stenosis. So then the same is true on the other side too, right? This is left heart things, aorta and mitral. So the same goes on the other side too, the tricuspid stenosis, TS, and pulmonic regurgitation, right? PR and TS. These are basically all your diastolic murmurs. So a systolic murmur would be tricuspid regurgitation. Right, that when your ventricle is contracting, blood is going back through the tricuspid valve into your right atrium. Right? And the hepatomegaly was obviously because of all the stuff happening in the liver and possibly even metastases to the liver. It's a pretty good topic that STEP definitely loves asking questions on. Small bowel obstruction is the next big thing. This is one of the favorites for this for GIT small bowel questions. They love questions on small bowel obstruction. We'll do some together too. So this is a partial or complete blockage of passage of bowel contents through the small bowel. It could usually be just due to adhesions, 60% of cases, but your question could be about hernias, neoplasms, intussusception, gallstone ileus, some IBD stricture, and even volvulus. Partial small bowel obstructions cause continued passage of flatus, but no stool, so they'll have a lot of gas. Complete SBO has no passage of anything. That's called obstipation. Where the passion is, so obstipation is a very interesting word. It's basically constipation, but you're also not farting. Right? So nothing is going through. Crappy abdominal pain at 4 to 5 minute intervals. Vomiting typically follows the pain. Abdominal exam is going to show distension, tenderness, possibly prior surgical scars, or hernias, hyperactive bowel sounds. Because everything's just in your bowels, but it can't come out. That could lead to ischemic necrosis and bowel rupture with prolonged or complete obstruction. Patients present with peritonitis, manifested by fever, hypertension, rebound tenderness, and tachycardia. And you have to be aware of that, peritonitis. You're going to see that in the question, and they're going to tell you the low-grade fever, and then you can get very confused by that. So don't fall for that trick in your patient. All right. In the United States, the leading cause of SBO in kids is a hernia. The leading cause of SBO in adults is adhesions. And you could get a question on SBO where both things are an answer choice, so based on the age, you have to pick hernia or adhesion. Here they're showing it to you, small bowel obstruction, images A and B. A is a supine x-ray of the abdomen showing dilated, air-filled small bowel loops with relatively little gas in the colon. And so you're having dilated loops. This is one, right? This is another area. This is another area. It's all stuck to it, right? All really, really fat, very wide. Okay, this is a very dilated area. Little gas in the colon. There's no air in here. This image is showing you a left lateral decubitus x-ray on the same patient, demonstrating multiple air fluid levels. So air fluid levels, remember, are level. So it's flat at the bottom. That's what you're seeing here. Right? Air fluid levels have flat bottoms. Right? So it's like a cloud sitting on the floor. That's what you're seeing there. When they're in their left lateral decubitus position. So this is an answer choice you have to remember. The next best step, order a left lateral decubitus x-ray to check for air fluid levels. That is also going to help you do the diagnosis, right? They tell you here, for diagnosis, best initial test, abdominal x-ray. Demonstrates a step-ladder pattern of dilated small bowel loops. A step-ladder pattern because you see how it has these lines in between. So let's say you're going up that step-ladder pattern. Most accurate test is to do a CT scan of the abdomen to further characterize the obstruction and evaluate what's causing the obstruction. CBC may demonstrate leukocytosis if there is ischemia or necrosis of the bowel, and lab tests often reveal dehydration. Lactic acidosis is a prognostic sign as it suggests necrotic bowel. If there's a lot of lactic acidosis, that sucks. Right, so that's something you have to be very careful with. I wrote here about gallstone ileus because I wrote pneumobilia and tumbling obstruction with vomiting as the stone advances to the ileum and finally lodges there. Patients present with obstipation and inability to pass flatus or stool. Cholecystitis is the most important risk factor due to biliary enteric adhesions after inflammation. So this is also something that can cause a small bowel obstruction. Right, this case scenario, let me show you a drawing of it. So that I believe is here somewhere too. Let's zoom out. So, small bowel obstruction due to gallstone ileus. So right here. So you see here on the left side, you have your gallbladder making a connection, a fistula, possibly due to adhesions, with the duodenum. Right? Now that same stone can travel through your small bowel and get stuck right here in the ileus. Right? Because the ileocecal valve won't let it pass. Once stuff gets stuck there, all the food that's being digested will get, will start backing up in the intestines, and then you're going to have dilated loops of bowel on your X-ray, small bowel, right? Really problematic, really problematic. So that's your gallstone ileus. That's what that's called. Another thing that can cause small bowel obstruction, right? And we're going to see that with ileus soon, because ileus and small bowel obstruction are often compared. You see small bowel obstruction versus ileus. Very interesting thing. You gotta make sure you can compare the two, and we'll come back to the comparison after we look at ileus. To wrap things up, initial treatment, fluid resuscitation. If it's a partial obstruction, supportive care could be sufficient. You can do a nasogastric suction, IV hydration, correct any of their electrolyte abnormalities, and Foley catheterization. Right? Avoid opioids and anticholinergic because both of these guys slow down GI motility. Opioids cause constipation, and anticholinergic means anti-rest and digest, anti-parasympathetic, and if you don't digest, you slow down GI motility. Right? If it's a complete obstruction, then you have to do surgery. Right? Exploratory laparotomy, ischemic necrosis is a problem, right? Refractory SBO symptoms are a problem, so you have to go ahead and check inside. Now compare small bowel obstruction, which we saw with air fluid levels and whatnot, with ileus, which is a loss of peristalsis without structural obstruction. So there's no obstruction now. Risk factors: recent surgery, GI procedures, severe medical illness, immobility, hypokalemia, or other electrolyte imbalances, even hypothyroidism, diabetes, and medications that slow GI motility like anticholinergics and opioids. There's many reasons ileus can occur. You're going to note diffuse constant abdominal discomfort, nausea and vomiting, and an absence of flatus or bowel movements, just like the complete obstruction part. Right? Just like your complete small bowel obstruction. So far, it's looking very similar. Physical exam will give you diffuse tenderness, abdominal distension, decreased absent bowel sounds. Right? Rectal exam is required to rule out fecal impaction in elderly patients. So how do you diagnose this? Well, consider clinical history and diagnosis. The best initial test is to do an abdominal film that shows distended loose of small bowel and large bowel with air seen throughout the colon and rectum. This is the main difference. Right? So you see SBO has no air distal to the obstruction. But since ileus is not an obstruction problem, air is everywhere. Air is seen throughout the colon and rectum. So the presence of air is how you differentiate, right? In ileus, there is air present throughout the small and large bowel on X-ray of the abdomen. There will be no air present in the SBO. SBO could have air fluid levels, but not air. Right? Treatment: decrease or discontinue the use of narcotics and any other drugs that reduce bowel motility, like the anticholinergics. Bowel rest, right? Temporarily stop eating. Bowel decompression: initiate a nasogastric suction, do parenteral feeds as necessary, and supportive care. So this is a little easier to deal with than your small bowel obstruction, where there's actually an obstruction. So look at the comparison between this image A, which is a small bowel obstruction, and this image here, which is showing you ileus. Right? So immediately the clear difference is that this has all these gray areas of air. There's a lot of air in here. Right? Within the bowels. There's air within the bowels and it's going all the way to the rectum. So that's showing you that this is ileus. Right? Whereas if you look at the bottom image, this one has small bowel obstruction on abdominal x-ray. There's air only up to a certain level and then it finishes. Then the rest of it is all empty. Right? And you see this bottom circle showing you distal large bowel decompression because there's no air in here. And you can easily actually see air fluid levels because of these flat lines that are right there. So I'm coloring the one on the right, but the left is the same thing. So you see the flat line right there. Right? Air isn't everywhere when it's small bowel obstruction. Small bowel obstruction has air up to the point where you finally find the obstruction. After the obstruction, there's no air. Nothing. Right? But here you can see air. You see air here too. Right? If you could draw the shape of an organ or shape of an empty area, that means that there's air in there. Right? So ileus has air everywhere. Small bowel obstruction has air up to the point of the obstruction. After the obstruction area, there's no air. And you're going to find air fluid levels. Big topic. Right here they tell you small bowel obstruction, etiology, prior surgery. That's usually it. So you look for surgery scars. Ileus has recent surgery, which was done just a couple days ago. And what else is the difference? So abdominal exam with small bowel or ileus pretty much shows the same thing. But there's a huge bowel sound difference because of the presence of air. Right? They're both going to have distension and pain and whatnot. Right? But in small bowel obstruction, you're going to have a lot of bowel sounds. It's like obstructing traffic. When traffic is obstructed, everyone honks. Right? With ileus, where there is absolutely no movement at all because you're at a red light, no one honks. Reduced bowel sounds. Right? Ileus has decreased movement, right? Decreased peristalsis. Other than that, the last thing is this. Large bowel dilation is absent because this is literally called small bowel obstruction. So there's no large bowel dilation. But here in ileus, even the large bowel dilates because nothing is actually moving correctly. Right, so the differences are pretty key, and as soon as you see one thing over the other, you pick the correct answer and you move on. Right, so here, again, another setting of differences. So SBO has nausea, vomiting, obstipation, acute abdomen, and hyperactive or absent bowel sounds. But here, in ileus, you have no flatus, right, and abdominal distension is going to occur, and there's decreased bowel sounds. Right? They could both possibly have absent balance sounds, so it's not a specific final difference between the two. But if you see hyperactive vowel sounds, you know it's SVO. Right? And then in ileus, since it's not an obstruction, poop will go. Poop will go once there's actually some peristaltic movement. But they don't fart because it's not like they have gas because of things not moving correctly. Right? Here they don't have anything. They don't have poop moving or gas. And since poop is not moving, you don't really make much balanced sounds either. In SVO, you're going to see air fluid levels. Right? With ileus, you're going to see air everywhere. There's no transition point. Right? So again, the differences between the two are pretty good, pretty easy to see. And when you're reading these questions, you just want to find the key difference between the two. This thing here, this is mesenteric ischemia. So mesenteric ischemia is very similar to thinking about like a heart attack, right? So this is intestinal angina in a sense. In step 1, that's how they refer to this, right? Intestinal angina. Insufficient blood supply to the small intestine. Just like with angina, you have decreased blood supply to your coronary vessels, right? So your heart doesn't get good blood supply. Why does it occur? Well, the most common cause is embolism. Emboli most commonly originate in the heart. Risk factors include atrial fibrillation or stasis from decreased ejection fraction. Acute arterial occlusions from thrombosis can occur, most commonly in the proximal superior mesenteric artery. Atherosclerosis is obviously a problem. And other causes could be non-occlusive arterial disease, like atherosclerosis of the mesenteric vessels, vasospasm, venous thrombosis due to hypocoagulable states, or just having shock. Presents with severe abdominal pain out of proportion to the physical exam, because they're just having a part of their intestine that's not getting enough blood and is going to die. Best initial test is do an X-ray or CT, where you're going to reveal this thumbprinting and air within the bowel wall pneumatosis intestinalis. So they don't have any good images of any of that here, right? But I've got all these, they don't have good images of any of that per se here. So let me see, I think I can show you that thumbprinting in my step 1 book. So mesenteric ischemia should be right here. Other intestinal disorders, right? So we go to this. So acute mesenteric ischemia versus chronic mesenteric ischemia. You see your intestinal angina, right? These people have atherosclerosis of one of these 3 major arteries, which can lead to postprandial epigastric pain, so they don't eat. Because every time they eat, they get pain. And the thumbprinting, let me see where I put that. No, I don't see I have a picture of it. Okay, let me put it into the video for you guys so you can see it. Right here. Thumbprinting. Let me see if I can find a good one. Wow, I mean, I guess if you're looking for it, you'll definitely see it very easily. So it's pretty different. Okay, I see why I didn't put any pictures of it. It's not really an easy thing to have pictures of per se. Okay, this picture is showing you basically a picture. Let me put it here for you guys now. So there you go. Now you can see it. So this is a little extreme though, because it's never going to be this apparent on your step. But if it is, then good for you. So the thumbprinting they're talking about, let me just fit this in correctly. Okay. The thumbprinting they're talking about is basically the this stuff here. Right? So this is the thumbprinting they're talking about. In fact, to me, what I really like looking for is, this looks like the space between toes, right? This space between toes. So that's kind of what you really see. They call it thumbprinting, right? And then of course you could see pneumatosis intestinalis. Pneumatosis meaning that it's lung-like. Right? Pneumatosis intestinalis because there's air. Let me grab the pencil again. Alright, this thing. Pneumatosis intestinalis because there's air in the intestines, right? In the small bowel. So, but not air fluid levels and not ileus related stuff. This is going to be someone who has mesenteric ischemia. Their pain levels are much more than what the pain is in ileus or small bowel obstruction. Right? Very different from each other. So you just do volume resuscitation, give them broad spectrum antibiotics. Okay, because you have to give the antibiotics. It actually helps them. Acute arterial thrombosis or embolism, then you have to do anticoagulation, of course, right? And then if it's all dead, then you have to do surgery to resect any of the infarcted bowel. Alright, usually it won't die too quickly because if you remember, the superior and inferior mesenteric arteries have a lot of collateral blood supply with each other. So if one superior mesenteric artery doesn't work, the inferior will take over and try to help it. Alright. Here on the right side, they tell you cholesterol embolism may occur following cardiac catheterization, and ischemia of multiple organs may be seen: bowel, kidney, pancreas, lower extremity skin, causing levator reticularis. This is a high yield topic. Right? They can throw any of these at you, and you have to understand that it was a cholesterol embolism due to the cardiac catheterization. So the question could actually start out with a patient who had a heart attack, and now they're having something wrong with the bowel, kidney, pancreas, anywhere. Even they could talk about the levator reticularis and they would describe it to you or give you a picture of it. You have to understand that it was due to a cholesterol embolism because of the treatment they just got for the cardiac catheterization. Alright. Very high yield stuff. Let's look at this question here. So this is a long question. 74, very old patient. 74-year-old woman is brought to the emergency department after acute onset of abdominal pain followed by syncope. She was in an exercise class when she suddenly had pain in the left side of her abdomen, quickly followed by a loss of consciousness for 30 seconds. So that's pretty crazy. She has nausea, dizziness, and diffuse abdominal pain, no seizure-like activity, chest pain, palpitations, rectal bleeding, or incontinence. Okay. There was no trauma. She was diagnosed with chronic lymphocytic leukemia 5 years ago. So that's a cancer, right? So CLL is a cancer, so that makes her pretty hypercoagulable. Other medical conditions include recurrent infections, AFib, that's a big one, diverticulosis and hypertension medications, apixaban, so that's a factor inhibitor for the hypercoagulability, but beta blocker metoprolol, amlodipine for blood pressure, and she has been taking them as prescribed. So it doesn't look like she's really taking anything for her AFib per se. Metoprolol, that's about it. She drinks 4 glasses of wine a day and does not smoke. On exam, she's lethargic, pale, has distress due to abdominal pain. So what is causing her this weird abdominal pain? That's what you wonder. Temperature, blood pressure is very low, very, very low. She looks like she's in shock. The abdomen is diffusely tender. Bowel sounds are low. Okay, bowel sounds are decreased. That's pretty big. Labs, well, hemoglobin is low. Platelets are 120. Okay, that's... Leukocytes are very high, coagulation. Alright, what is the most likely diagnosis? So this question was very intriguing because people were very confused. 40% chose the right, 40% chose the wrong. 20 chose bowel perforation, 20 chose mesenteric artery occlusion. But the correct answer was just splenic rupture. So what happened to her? Acute onset abdominal pain, shock, and acute anemia indicates splenic rupture, right? Especially the acute anemia. An uncommon but life-threatening complication of CLL, which is the reason you would think of splenic rupture, the fact that she has CLL. Most cases of rupture are associated with blunt abdominal trauma. Atraumatic cases can also occur. In the setting of concomitant anticoagulation, the apixaban she's taking for her AFib, the chances of rupture are greatly increased. Focused abdominal ultrasound or CT scan demonstrates free intraperitoneal fluid. Splenectomy is the basic management of choice in hemodynamically unstable patients, but catheter-based angioembolization may be attempted in stable patients. Bowel perforation can present with diffuse abdominal pain, signs of peritonitis, and shock. However, it would not explain an acute drop in hemoglobin. Right? So bowel perforation doesn't make sense. Mesenteric artery occlusion causes abdominal pain, but exam is usually unrevealing with pain being out of proportion to the findings. This diagnosis is unlikely since she's taking apixaban. Right? She wouldn't get an occlusion since she's taking apixaban. she's not really going to have any thrombosis occurring. Right? And bowel perforation could make you lose blood, but it wouldn't cause that acute of a drop in hemoglobin. Right? In fact, with the perforation, you would have trouble of the air going everywhere. Okay, so good questions indeed. And from here, there's a bunch of questions, and we move on to large bowel. So in the next video, we'll actually go through these questions together to visit and see what's happening in them, and start up with large bowel.